Now I invite Dr. Sendil. Today we are having the Neurosciences Forum, which is being conducted along with IMA Pollachi branch, AMS wing. So I invite Dr. Sendil Kumar sir to kindly start the program. IMA
Thank
President
you,
of the
sir.
Pollachi.
Thank you, sir. I am a prayer. May everybody be happy. May everybody be healthy. May everybody be free from pain. May everybody be free from sorrow. May we be the healing cure beyond every greed and lure. Christian prayer. Dear Lord, thou great physician, I kneel before thee. Since every good and perfect gift must come from thee, I pray. Give skills to my hands, clear vision to my mind, kindness and sympathy to my heart. Give singleness of purpose, strength to lift at least a part of the burden of my suffering fellow men, and a true realization of the rare privilege that is mine. Take from my heart all guilt and worldliness, that with simple faith of child I rely on thee. Thank you, sir.
Invite Dr. Sendil Kumar sir to give the welcome address.
Thank you, sir. On behalf of IMA Pollachi branch, AMS wing, I welcome our speakers for the day, Dr. K. Ashogan sir from Ramakrishna Hospital, Coimbatore, Dr. Ramakrishna Ishwaran sir from Neuro One Hospital, Trichy, and our course directors, Dr. Rajesh Babu sir and Dr. Vikram sir, and all our Pollachi branch members and state members, and from throughout the country, Neurosciences Forum members. I welcome you all for this third CME for the year. Thank you, sir.
So today we will be having the programs. First we will be having the talk by neurophysician and Dr. K. Ashogan sir, and the second talk will be by Dr. Ramakrishna Iswaran sir. So I welcome you all for this Neurosciences Forum meeting, which has been continuously been conducted for the past 6 months. And every time we are having one neurophysician and one neurosurgeon. And in the coming month, we are going to have the Neurotrauma Society conference at Goa on August 8, 9, and 10. I invite all the neurosurgeons who are participating in this program and PG students who are also in the program. Please register and join the Neurosciences, the Neurotrauma Society conference at Goa, and get updated for the current scenario of head injury, because there are going to be a nice topics. I am at present the treasurer of the Neurotrauma Society of India. I welcome you all for this program. So now I invite the speaker of the day, Dr. K. Ashogan, to give his talk on endovascular treatment of acute ischemic stroke. Naveen, biodata. Dr. Ashogan sir is a senior consultant neurologist, the head department of the neurology, Sri Ramakrishna Hospital, Coimbatore. He is graduated from Chengalpattu Medical College and MD from Stanley Medical College and DM from Madurai Medical College under Professor KS. And a membership life member in Indian Academy of Neurology and Neurological Society of India, active member of American Academy of Neurology, live member in Indian Stroke Society, ex-president Coimbatore Academy of Neurology, ex-president of Tamil Nadu and Pondicherry Association of the Neurologists. Presented papers in national and international conferences on stroke and epilepsy, special interest in stroke therapy, and he is stroke program medical director at Sri Ramakrishna Hospital. Current position, presently he is a senior consultant neurologist, head of the neurology department at Sri Ramakrishna Hospital, Coimbatore. Welcome you, Dr. Ashogan sir, to give your lecture.
Thank you. Thank you, Dr. Rajesh Babu. Thank you for your kind introduction. Respected seniors, my colleagues and dear friends, I thank IMA Pollachi branch, AIMS wing and the Neurosciences Forum for giving me this opportunity. I thank both Dr. Rajesh Babu and Dr. Vikram, course directors, for their excellent coordination. I thank all of you for sparing time to this web meet today. My greetings to my co-speaker, Dr. Ramakrishna from Trichy. Today I'm going to talk about our experience at Sri Ramakrishna Hospital, Coimbatore, in treating acute ischemic stroke patients with endovascular treatment, that's mechanical thrombectomy, angioplasty, and stenting. I will make it very clear, I'm not going to talk about the thrombolysis today. I'm going to talk about mechanical thrombectomy and neuro intervention. So, the three main principles of acute stroke care is achieve timely recanalization of the acute artery and reperfusion of the ischemic tissue, optimize collateral flow, avoid secondary brain injury. These are three main principles. Three zones of injury that occur following large vessel occlusion.
Speaker sir, konjam mic பக்கத்துல வைங்க சார். கொஞ்சம் mic உங்க voice கொஞ்சம் குறஞ்சிருச்சு சார்.
இல்ல நல்லா கேக்குது நல்லா கேக்குது
சார். No, it is okay sir.
நல்லா கேக்குதுங்க சார் நல்லா கேக்குது.
Three zones of injury may occur following large vessel occlusion. The central core is called ischemic core zone. That's the tissue which is irreversibly injured. You cannot do anything with that. Next is ischemic penumbra, the most important area, that is ischemic but still viable cerebral tissue. If you can put in something and if you can do something to recanalize, then probably it will get reperfused. That's the area, ischemic penumbra. Third is benign oligemic zone. That's the area with minor reduction in tissue perfusion, but that does not place the tissue at risk. Ischemic penumbra. Ischemic penumbra is an area of brain tissue that is viable, but is critically hypoperfused. It's hypoperfused, reduced, and will progress to infarct in the absence of timely reperfusion. If you don't do anything, if you don't reperfuse, if you don't intervene in a timed manner, then it will die permanently. Next is timely reperfusion of therapy is the most effective maneuver for salvaging ischemic brain tissue. That's the penumbra. Thrombolysis within the window period of 4.5 hours. So, if you want to do thrombolysis, the window period of thrombolysis is 4.5 hours from the stroke onset. Now, if you wait and if it is a longer duration, that you are not going to recanalize or reperfuse the tissue which is at risk. That's why we set a target of 4.5 hours as a golden period. Next, suppose if we miss it within 4.5 hours, then what else? We can go for mechanical thrombectomy. The window period for mechanical thrombectomy is 6 hours. That's what we are setting right now. Window period is 6 hours. But there's another entity called extended window period, where for late presenting strokes up to 6 to 24 hours, you can go for mechanical thrombectomy if other things are satisfied. I'll tell you what. Collateral circulation. Primary collaterals refers to a circle of Willis, that is ACOM and PCOM, anterior communicating artery and posterior communicating artery. These are the primary collaterals. Secondary collaterals refers to ophthalmic artery and the leftomeningeal arteries. Tertiary collaterals refers to newly developed vessels through angiogenesis. DSA, digital subtraction angiography, is a gold standard to evaluate collateral anatomy. Of course, collateral you can look at with the CT angio, with the MR angio, but still the gold standard is DSA. Intravenous thrombolysis and EVT. Of course, intravenous thrombolysis is the standard of care for eligible patients, but has treatment limitations. So, short time window, as I told you, only 4.5 hours. But if you happen to see the patient after 4 hours, what are you going to do? So, short time window. Patients with increased bleeding risk, where we cannot lyse the patient already, patient is at the bleeding risk, and if you thrombolyze, bleeding will further worsen. proximal artery occlusion, or it's called large vessel occlusions, which causes a large clot. Such a large clot cannot be lysed with your thrombolysis. It needs something else, that's thrombectomy. Hence, these patients should be considered for EVT, that is endovascular therapy, because these are more disabling. So, the mechanical thrombectomy. Who are the candidates for mechanical thrombectomy? Candidates with acute endovascular, acute stroke for endovascular therapy are the patients that are 18 years and above. We don't do thrombectomy as of now for patients below 18 years. And NIHSS, that is National Historical Stroke Scale, score is 6 and above. This is a very short this thing. NIHSS, it's up from 0 to 42. 0 means no stroke. 42 is the maximum score, worst stroke. 1 to 4 is mild stroke. 4 to 14, moderate stroke. 14 to 21, moderate to severe stroke. 21 above up to 40 is very severe stroke. So this is the score utilized to assess the severity of stroke, NIHSS. And the time from symptom onset to groin puncture should be less than 6 hours. And in some cases up to 24 hours. If evidence of sizable ischemic penumbra is seen on perfusion imaging. And the presence of large vessel occlusion, that must be there. Diffusion MRI showing core volume less than 50 ml according to Bounce criteria and less than 70 ml according to diffuse criteria. But what are the contraindications for thrombectomy? Intracranial hemorrhage. Of course, you cannot do thrombectomy if there is intracranial hemorrhage. Second is large infarct core with the minimal. What does it mean? It means the infarct core is the central infarct area and the surrounding area is equivalent to penumbra. The equation is 1:1.5. If it is 10 mm infarct, 15 mm should be penumbra. If it is otherwise, like if it is 15 mm core and 10 mm penumbra, just the reverse. You cannot. There is no use of thrombolysis. So large infarct core with the minimal penumbra is a contraindication for thrombectomy. Not contraindication, the patient will not be benefited. That's it. Then small vessel occlusion. So this thrombectomy is always for large vessel occlusion. We don't do this for small vessel occlusion. I tell you later, what do you mean by large vessel occlusion? We see all the 3 vessels, ICA, MCA, and Basilar Artery. Internal carotid artery, middle cerebral artery, and the Basilar Artery. These are 3 vessels we target, not other vessels. Middle cerebral artery also is called M1. You get M1, M2, M3, 3 divisions. The M1 only we take it as large vessel. M2, M3 goes distal and we don't target. So there is a small vessel occlusion, no need for, rather no use of thrombectomy. Coagulopathies that cannot be corrected. Of course, any coagulopathies cannot be corrected. It's going to bleed with the thrombectomy. We don't do it. And elevated bleeding more than 180 or 110 that cannot be corrected. It's a very important statement. See, 180, 110 is not a contraindication. It can be corrected for another 10 minutes with the Levitt-Law. It can be corrected. Only thing for another half an hour, 40 minutes, it cannot be corrected with Levitt-Law, etc. If it is still 180, 110, then it's going to be a problem. Thrombectomy. The trials, just for information, in the endovascular treatment, that's mechanical thrombectomy. We say it's anterior circulation and posterior circulation. Anterior circulation will mean internal carotid artery and the middle cerebral artery. That's the anterior circulation. Basilar artery and the posterior circulation. All these trials, mind you, all these trials throughout the world, now they are mainly for anterior circulation. That is ICA and MCA. Mr. Clean, Reeve, ASCAT, SK, Swift, Prime, Extend, Thrash, etc. etc. What I'm trying to tell you is this thrash, they randomize patients up to 4.5 hours from symptom onset. Higher rates of good outcome with the Swift and Prime, X and IA trials. Classical window 6 hours. Then Escape and Revascat 10, they did thrombectomy of 8 hours. So they started with the 4.5 hours like thrombolysis. Then they went up to 6 hours thrombectomy. Then other trials they went up to 8 hours. Still, the story is not over. Next, they came with expanding the time window. The concept of tissue window versus time window has proved useful for selecting patients for mechanical thrombectomy up to 24 hours from symptom onset. So we start with 4.5 hours, then went up to 6 hours, then went up to 8 hours. Now we can go to 24 hours for thrombectomy. But for thrombolysis, still the same, only 4.5 hours, not more than that. So this extended window, this includes wake-up strokes and the strokes of unknown time of onset. What is the wake-up stroke? Patient goes to sleep by 11 o'clock, 10 o'clock at night, and gets up morning by 6 o'clock, 5 o'clock. As he is getting up from the bed, he is getting up with the stroke. So we really do not know at what time this had happened. So these wake-up strokes, where the time is not known, unknown time of onset. Such as these cases, if there is mismatch between the DW and flare in the MRI, and the core is small, little collaterals, peripheral collaterals, still up to 24 hours you can take for thrombectomy. Non and diffuse, these two clinical trials showed excellent clinical outcomes in patients lived up to 24 hours from symptom onset. So this endovascular therapy we do in anterior circulation and post circulation in acute ischemic strokes. As I told you already, anterior circulation means internal carotid artery and middle cerebral artery. Post circulation means basilar artery. So what we do, first we do empty mechanical thrombectomy. And if the vessel is not opening, we go for angioplasty. Still, if it's not opening, we combine with stenting. Mechanical thrombectomy, angioplasty, and stenting, all the three. So start with mechanical thrombectomy. If the vessel is not opening, reocclusion, angioplasty. Still, if it is not opening, the rescue procedure is stenting. Failed thrombectomy. We talk so much about thrombectomy. What do you mean by failed thrombectomy? The thrombectomy may be failed in some of the cases. What cases? ICAD, intracranial atherosclerotic disease. If the disease is very severe atherosclerotic disease, it may fail thrombectomy. And if there is a calcified valve, adherent thrombi, wall is calcified, thrombus is very adherent to the wall, where it's very difficult to manipulate and remove the clot. Or dissection of the vessel, are difficult to vascular access. Some of the vessels are very tortuous. It's very difficult to going through the vessel through the microcatheter. And the formation of distal thrombolysis. What do you mean by this? You are breaking the clot. As you are breaking and sucking the clot, as you do that, the fragments are disseminated and go to the distal area to get blocked. And that again becomes failed thrombectomy. And say declared failed thrombectomy if no recanalization of the 3 passes. That's what the international forum says. But we go up to 5 passes. Even after 5th pass, it is not opening, we call this failed thrombectomy. And acute intracranial stenting is a promising bailout in such of these cases. So, such as this case, we go for stenting. So, we will go for the case scenario. First case, 46-year-old male admitted to sudden onset left hemiparesis, slurred speech, and the left EMN facial palsy. Presented 9 hours after stroke onset. So, at the face value, you can say is not a candidate for thrombolysis, but he has crossed the 4.5 hours window period. And the known hypertensive on treatment, alcoholic smoker, BP 140/90, is the patient presenting with left hemiparesis. And is this called DW, diffusion varied MRI showing a large right MCA infarct. This is the infarct, right MCA infarct. And that's the MR angio where this is called the MCA. It's cut off here. M1 occlusion is called M1 occlusion, right MCA, M1 occlusion. And for him, primary or direct thrombectomy was done. What do you mean direct thrombectomy? Suppose the patient comes to you within the 4.5 hours of the window period of thrombolysis, we go for thrombolysis, then take note of thrombectomy if it is a large vessel occlusion. But if the patient is coming to you up to the window period, after 4.5 hours, we don't have any other thing to offer, so directly go for thrombectomy, that's called direct thrombectomy without bridging. So that was his DSA, you can see that M1 occlusion. And it should go like that, but it's totally blocked here, M1 occlusion. And these are the plots retrieved from the M1 occlusion. So if you can make out such a beautiful, very good recanalization and revascularization. Recanalization means opening the vessel. Revascularization means good reperfusion. Both. So that is ACA. This is MCA. Very good. Recanalization and reperfusion. So this is the status of the patient just 5 days after thrombectomy. We could make him walk, or he is walking without any deficit, and the MRS is 0. What do you mean by MRS? MRS is modified ranking scale. Scale is like 1 to 6, and of course 0, no deficit. 1, some minimal deficit, and 2, 3, 4 likewise, and 5 is totally bedridden, and 6 is dead. Likewise, MRS is no deficit, 0. Sorry. Case 2, again large vessel occlusion, same right M1 occlusion, for him thrombectomy, angioplasty, and stenting done. Previous case, we did only thrombectomy, he became all right. But here we had to do angioplasty as well as stenting. 48-year-old female admitted with sudden onset of giddiness, left upper bowel weakness, and slurred speech since 8 hours. Again, it's 8 hours out of window period for thrombolysis. So no diabetic and treatment, not a hypertensive, RBS 160, BP 140/90. CT brain done outside showed hypertension MCA sign. The hypertension MCA sign means there is thrombus in the MCA that we can measure the CT itself. He came with the CT which was done outside that showed hypertension MCA. Right MCA infarct was taken off for thrombectomy. PSA for the right M1 MCA occlusion. Embo trap was placed and small part was retrieved. Post-procedure injection showed significant 99% stenosis in distal M1. Clot removed, but underlying stenosis is about 99%. So repeat check angio of 10 minutes showed the re-occlusion of M1 MCA. So angioplasty done. But after angioplasty also again check injection after 10 minutes showed the re-occlusion of the vessel, and MCA still not opening, and stenting done, open the vessel. Patient, this is a patient with the left hemiplegia, the left hemiplegia, acute onset. Right hand, see, this is the CT which was done outside. She came to the CT. This MCA, dense MCA, blind CT, dense MCA side. That shows thrombus in MCA. So if you look at the ESA, that is MCA. It's blocked. That is ICA in terms of collateral artery. That is MCA. So embedded trap placed and clots retrieved. As you are retrieving the clots, you are getting distal flow. Very well seen now. But if you look at this, still it's narrow. So re-occlusion, see, back to square one, totally de-occluded. So after the angioplasty, still the stenosis is there. So for you, stenting done, stent in place, and after stenting, see, completely opened up. Very good flow, and look at the revascularizations. Good, it's good. It's called TC3. TC we say 1, 2, 3. TC 0 is normal. TC 0 no flow. TC1 mild flow. TC2 moderate, and TC3 normal flow. This is TC3. And 8 days after thrombectomy, of course, we could make a walk with little support. Yeah, little support. After 25 days, look at the way she is walking. Without any help, she is walking near normal. Going to the next case is again left M1 occlusion with underlying stenosis, thrombectomy, and stenting done. The 42-year-old male admitted right hemiplegia, aphasia, etc., etc. Again, 12 hours after the onset, and recent onset hypertension treatment. BP 170/100, not diabetic. MRI Brain left ganglion infarct. MRI angio left occlusion taken from direct thrombectomy. Clots retrieved from M1, but the re-occlusion we did stenting, angioplasty, then re-occlusion we did stenting. So patient with right hemiplegia and aphasia, this is MRI showing the infarct, left ganglion capsule infarct. So if you look at this, that's the ICA, internal carotid artery, that is MCA. MCA is totally blocked on the left side. So he presented with right hemiplegia and aphasia, left is totally blocked, and ESA showing right M1 occlusion, left M1 occlusion, and stent in place, stent retrieval. And if you look at this, after retrieval, still the stenosis persisting. So, PTA balloon installed, transfemoral angioplasty balloon installed, and even after ballooning, the stenosis is still present. So, stent, MCA stent, this is the stent, the CT is called cone beam CT within the angio suite itself. That shows the stent in place. So, look at this. Now, it's totally recanalized and very good reperfusion. Yeah, same thing. So the MCA fully, this is called TC3, total reperfusion. And in just 3 days after thrombectomy, we could make him walk with little support. And 7 days after thrombectomy, he is on his foot and walking without any support. Next case, this one with the right hemiplegia and aphasia, non-hypertensive. If you look at this, there's the large infarct on the left MCA territory. This MRI that shows left. That's the MC on the right side, but left MC, ICA on the right side. Left ICA is totally blocked, as well as left MC is not seen. Here again, there's the dense MCS sign. It shows again thrombus in the MCA on the left side. So that is CT angio, where there is no ICA and MCA. Again, CT angio, you can make out nicely. That's the total cutoff of the internal artery on the left side. So presented within 4 hours of stroke onset. So all the time I was talking about the patients presenting out of window grade. Now he has presented within 4 hours of stroke onset. He is within the window grade for lysis. So he was given intravenous connector place immediately, then taken off for mechanical thrombectomy within 30 minutes after bridging with IVT. This is called bridge therapy. First to give connector place, lyse the patient. Then after that, we take him for thrombectomy. You are bridging with IVT. That's called bridge therapy or bridging therapy. Why to bridge? Because we had seen such a large plot in the ICA and plot in the MCA also. It's not going to lyse with your connector place. So you have to bridge it with EVT. Look at this. So even after giving connector place, the DSA shows nothing happened. There's total block on the ICA, left ICA. So these are the clots retrieved from the ICA. So after retrieval, ICA is opening up, and later MCA also. Very nice flow in the MCA also. ICA and MCA both opened up very nicely. So is the patient just a week after the thrombectomy, such a large plaque. And after another 1 week, he is getting more stabilized. So in a month's time, we could make him walk with the support, of course. And later, after 90 days, he was much more better. So another case, this 35-year-old male admitted to sudden onset right hemiplegia, aphasia. He was delirious. He was an alcoholic and registered binge alcohol, chronic smoker. He presented within 3 hours of stroke onset. Because of long extending thrombus, primary thrombectomy planned for him. Why? Because we offered thrombolysis and thrombectomy. But patients' relatives were willing for only one mode of therapy. They were telling you go for either lysis or ectomy. We cannot offer for both. So we straight away went in for thrombectomy, primary thrombectomy. Even though you presented within 3 hours, you have to go for primary thrombectomy. And person with left hemiplegia and aphasia, this large left MCA infarct in the DW. This is called ADC. ADC is suppressed. And this is called a flare. The patches just started appearing. If you see the MR angio, the ICA and MCA totally absent. This is the ICA on the opposite side. Here it is absent, totally absent, as well as MCA. That is total cut off the MCA. And the DSA, again, MCA is absent, stent placed, and as we are clotting retrieving the clots, the ICA is opening up, and the blood slowly entering into the MCA. And later, after retrieving from the MCA, that's also opening up. That's MCA. This is the distal flow. Very, very nicely opened up. Now look at this. The total MCA is totally clear now. Fully open. So this is the longest clot we ever got from the ICA. Such a long clot. And other clots also. So these are the clots retrieved from the MCA. Such a big clot burden. And just in a week's time, we could make him sit up. And at the time of receive, after I think 45 days, he could walk with the support. So next case, here again we have the correct angioplasty, mechanical thrombectomy, angioplasty, and stenting for 99% stenosis, proximal ICA and MC occlusion. This 50-year-old male, sudden onset laryngoscopic switch, left hemiparesis and laryngoscopic switch, dysarthria. So left hemiparesis, dysarthria, sudden onset. MRI Brain angio revealed acute infarct of right frontoparietal lobe. That's the infarct, right frontoparietal lobe on the right side. So that's the ADC on the right side. That is flare. So it's changes started occurring. And if you look at this MR angio, this ICS absent, MCA on the right side, both are absent. That is the MCA on the left side, but that is the right is absent. DSA, if you look at that, see, complete, total narrow stenosis of the ICA at its origin, And clots retrieved from MCA and is slightly opening up. And after more retrieval, yeah, now MCA is filling up very well. Reperfusion is good. Recanalization, reperfusion is good. But what's happening? The proximal 99% stenosis, you have to do balloon, PTA balloon. With that, it becomes complete. Good recanalization and reperfusion. So these are the clots retrieved. And 7 days after thrombectomy, yeah, we could make him walk with the support. And 30 days after thrombectomy, look at the way he is walking. Yeah, a little limp, but he is walking without support. That's the thing. So that's all about anterior circulation. One or two cases with the basilar artery, posterior circulation. We have been talking about anterior circulation all the time. Now we come to the posterior circulation. So basilar artery is the neurologist equivalent to the cardiologist left main coronary artery. How the cardiologists are making big noise about left main coronary. Same thing, our basilar artery for neurologists. Occlusion of either artery can be fatal without rapid reperfusion. So evidence for EVT, the endovascular therapy for acute basilar artery occlusion is limited to 2 RCTs till May 2022. Imagine, till May 2022, just not about 3 years till that time. Evidence for EVT limited only with the 2 RCTs. There's basics and the best. Basics is basilar artery international cooperation treaty, and the best is basilar artery occlusion EVT versus standard medical medicine. These trials concluded telling EVT did not differ from medical therapy. What do you mean by that? Just give aspirin and something, and nice and should be all right. No need of EVT. EVT is not going to improve the clot burden in basilar artery. That's what these trials showed till May 2022. But there are some registry data which supported, mainly Chinese data, supported EVT in basilar artery. Basics and best. These 2 RCTs were hampered by select enrollment, slow and low recruitment, large number of patients treated outside of the protocol, high crossover rates, and lack of advanced imaging. So, mind you, this CT perfusion and MR stroke protocol they were doing left and right. But all these protocols, they were doing only blind CT. Blind CT, non-contrast CT, has limited sensitivity to assess strokes involving post-circulation. But ultimately, we say if you want to assess post circulation, go for MRI, or CT perfusion or contrast CT. Plain CT is not going to be very useful. That's what they used in basics and best, and telling it was useless, but it's not so. Then came attention bioc. Attention is a Chinese trial, like this bioc is a Chinese trial. These two trials, results of these trials presented at Acute Stroke Organization Conference in May 2022, very recently indicate that EVT is superior to medical margin for selected basilar occlusion cases. Attention trial within 12 hours of symptom onset, bioc trial 24 hours of symptom onset. Says, and of course, we are following these trials, attention and bioc, and we are getting good results. Yeah. So, one or two cases. This 25-year-old male admitted with sudden onset weakness of left arm and leg and sliding of switch since 18 hours. Imagine he had presented to us 18 hours after stroke onset. No comorbidities, BP 130/80. MRI brain, acute infarct in the left thalamus, right midbrain, bilateral cerebral, severely narrowed, occluded distal right lateral artery, distal basilar artery, and bilateral superior cerebral artery. Look at this MRI, bilateral cerebral infarcts, UW, left thalamic infarct, right contraindications infarct, and infarcts everywhere in the posterior circulation. So the cerebellum, midbrain, palms, midbrain, and thalamus, everything comes under the posterior circulation, separated by basilar artery mainly. So MR angiogram showed the basilar artery top occlusion. DSA confirmed basilar top occlusion, and we was taken for primary thrombectomy 18 hours after stroke onset. So if you look at this DSA, that's the basilar artery. Up to here it's patent, but it's blocked distally. So that's distal occlusion of the basilar artery. This is the clots retrieved from the basilar artery. And after the retrieval, look at this very nice flow. You can make up the PCS bilateral, superior cerebral artery and basilar artery. Very nice reperfusion and recanalization. 3 days after thrombectomy, we could make the patient, and command is trying to lift his hand. So 1 week after thrombectomy, he is little more stabilized, and still is an ICU. Why? Because any brainstem stroke or respiratory occlusion will have alpha. So difficulty in swallowing this dysphagia, so he is an ICU. For 14 days after thrombectomy, we could make him stand with support. Just 45 days after thrombectomy, when he came for first review, look at the nature of improvement. Next case is like thrombectomy with angioplasty. So here, thrombectomy itself was not useful, so we have to go for angioplasty also. 50-year-old male admitted with sudden onset giddiness, alert switch, and left hemorrhages since 12 hours. Hypertensive and irregular treatment, BP 160/100, chronic smoker, alcoholic, etc. And technopher, because he came only 12 hours after the stroke. So technopher direct thrombectomy, clots retrieved from basilar artery. But proximal basilar artery showed a tight stenosis, 99% stenosis. So this is the contraindication infarct, right? Contraindication infarct. And this MR angio, basilar artery is not visualized. This is the area supposed to be present basilar artery, it's not there. These are ICAs. So DSA again, the vertebral artery, but this is the basilar artery. It's not seen well. It's totally occluded. The stent in place. I mean, clots retrieved through the stent retriever from the basilar artery. After that, you can see distally this artery is very well recanalized, but proximally there is tight stenosis. Proximally, that's the area. So we have to do angioplasty. See, this is the tight stenosis and angioplasty, partial opening, but the opening is good to perfuse the distal vessels. So start with that, and just 2 days after thrombectomy, nicely. And just 4 days after thrombectomy, we could make him sit up. Still, these are right side is because global palsy, posterior circulation for global palsy. Same, 7 days after thrombectomy, we could make him stand. And 14 days after thrombectomy, look at that. Right sleeve is out, he is taking what he is washed with the minimum support. And the 45 days after thrombectomy, look at the improvement. I don't think we can get this sort of improvement versus circulation with any other mode of therapy. Last case, bear with me, last case. That's a basilar occlusion. Here, bilateral vertebral artery stenosis. This basilar artery has already occurred along with that bilateral vertebral artery stenosis associated with myocardial infarction, ventricular tachycardia, cardiac arrest, everything, whatnot, everything is there, but still revived. With the 76-year-old male, sudden onset right hyperplasia and the slurred switch since 8 hours. 8 hours. EM hypertension treatment, but 8 hours thrombolyzed outside. In the quality, he was thrombolyzed outside because he presented there within the window period. They did CT, looking at the CT, they thrombolyzed. Then he came here for further management, but after coming over here, worsening of symptoms. CT brain done outside showed only left PCA infarct, but MRI done here showed hyperacute infarcts, pons cerebellum and left occipital lobe. So MRI total occlusion of the basilar artery. ESC showed hypoplastic right outer artery. So right outer artery hypoplastic, left vertebral artery severe arterial stenosis. Post-plastic 5 minutes check angio showed near total occlusion of the left vertebral artery and stenting done for which. Fourth POD, he developed the sudden ventricular tachycardia and ear swelling in ICU due to MI. Cardioverted, echo showed severe LV dysfunction, EF only 30-38%. Slowly recovering, weaned out the ventilator 10 days later, we could make him sit up in chair another 10 days. Another 20 days, we could make him stand also. This is the patient, person with just right hemiparesis, but CT done outside showed only the occipital infarct, left occipital infarct, he was thrombolyzed, but it became worse. Here, what we did, the MR DW, contained infarct and cerebral infarct. So these are the cerebral infarcts. And this is the original occipital infarct, which we had outside also. Look at this basilar artery is totally absent. This ICA, but basilar artery totally absent, as well as vertebral arteries, nothing is seen. So right vertebral critical stenosis, this is the hypoplastic vertebral artery. Left vertebral artery stenosis not visualized, and basilar artery is occluded. And post-procedure injection, little opening of the basilar artery, but the left vertebral stenosis still persistent. Look at this. So restenosis and stenting done for that, and after that reasonable forward flow and good reperfusion and revascularization, but still that stenosis partially present, but stent is working well. Look at this, very good recanalization, reperfusion. Both the PCS are visualized. So just 10-12 days after the thrombectomy, after the myocardial infarction and everything, we could make him sit up. And another 20-25 days, I think, we could make him sit. Likewise, we could make him stand in a month's time. And still he's doing well. So 1 year. So concluding, mechanical thrombectomy markedly improves outcomes of patients with stroke due to Rogers occlusion. Rogers occlusion strokes presenting within the window period of thrombolysis. We do bridging therapy and sometimes direct thrombectomy. That's what we do, both IVT and EVT, and sometimes direct thrombectomy. Strokes presenting out of window period of thrombolysis and late presenting strokes, we have the option of mechanical thrombectomy to revascularize the ischemic tissue. If no recanalization or revascularization after thrombectomy, we do angioplasty and stenting. With these treatment schedules, there is a paradigm shift in microscope management, and our patients are getting better. Thank you. That's all I can. And bear with me, and probably I have a little over exceeded. Thank you, sir. Thank you, all.
Thank you.
I invite Dr. Ramakrishna Iswaran sir. Naveen.
Sir, sharing, sir.
Dr. Ramakrishna Iswaran sir is a consultant neurosurgeon and director of the Neuro 1 Hospital, Trichy. Did his MCH neurosurgery from the NEMHANS Bangalore 1988, Best Outgoing Student Medal, and Assistant Professor Neurosurgery, St. John's Medical College 1988 to 1990, private practice at Trichurapalli for 34 years, 8 publications and 20 textbooks, CME chapters, multimedia tutorial CDs. Professor M. Nadarajan Gold Medal, Neurospinal Surgery Foundation of India 2002, Abdul Kalam Award, St. Joseph College, Trichy 2016, Professor B. Ramurthy Oration Award, Institute of Neurosurgery, Chennai 2017, Lifetime Achievement Award, Tamil Nadu Association of Neurology Surgeons 2019, and Carnatic Classical Music, Lyric Writing, Composing Music. I invite Dr. Ramakrishna Iswaran to give his talk on the decision making in cellular masses.
Thank you, Dr. Rajesh Babu, for that introduction. Am I audible?
Yes, sir.
Okay.
Yes.
Thank you, IMA Polachi, AMS Wing, and the Neurosciences Forum. I'm very happy that you've been doing this as a continuing medical education program. I'm very happy that you've been able to invite me for giving my talk. And I'm going to share my screen now. Is it visible to you all?
Yes, sir.
Okay. So that is my hospital where I work for the last, we started in 2016. Before that, I was working in other hospitals in Trichy. I want to introduce you to Professor Michael Lawton, who is at the Barrow Institute, one of the world famous neurosurgeons. His department has 3,000 beds for neurosurgery and neurology in USA. And we are fortunate to have him here in the Trichy meeting of the Tamil Nadu Association of Neurosurgeons last April, where he gave a webinar on his pet topics. He has written actually 2 books. One is called 7 Aneurysms. The other is called 7 AVMs. And now the talk he gave to us the other day was on 7 cavernomas, which is going to soon come out as a book. Right now it's a journal article. So based on this, I have called my talk as 7 cellular masses. Tales and lessons. Tales means we'll give you the clinical vignettes of the patients and we'll see what we can learn from these patients. Not all of them had required surgery. And that is the reason why I'm projecting this in a general forum where there are a lot of generalists also. Now, my first patient is Mrs.C, 24 years, 7 months of spontaneous galactorrhea. That is her symptom, presenting symptom. For the last 1 month, she's got recurrent headache, mostly right temporal throbbing, lasting a few minutes. She has a sensation of her eyes bursting out. And for the last 1 week, she has diminution of vision in the outer half of the right eye. But on examination, her fundi look normal. She's not very cooperative because of her headache and because of her psychological makeup. For visual field testing, there was no obvious endocrinopathy. We could not make out any sort of features of any endocrine abnormality. Her prolactin level done at another hospital was 70.32, which is high. For any person, this 70.32 is high. And this was the MRI that had been done. You can see that there is a mass that is involving the cella. And this is a measurement of the mass. So this patient had been posted for transfemoral surgery at another hospital. And she got discharged from there and she came for a second opinion. Now, what do you think is missing in this whole story? What is the thing which I did not give you? The important thing is the menstrual history. If a person has got galactorrhea due to a pituitary lesion, we expect them to have amenorrhea. Whereas this patient had her normal menarche. She had actually excessive bleeding in most of her cycles. She was married, she had a child, she had breastfed the child, she had resumed having menses. And for the last 7 months, she's got polymenorrhagia, which has led to anemia. That means she's been having severe bleeding, which is totally incongruent with the story of a prolactinoma causing galactorrhea. Her last menstrual period, in fact, went on for 28 days, which means there is really something wrong with her menses, and it's not due to the elevated prolactin. So there is something else that is wrong with this patient. What is wrong? Can anybody guess? You can unmute yourselves and speak. Okay, this is the kind of picture that we had on the MRI. You are able to see the posterior pituitary over here, and you're seeing the whole mass of which is coming out is a suprasellar mass. This is the. Are you able to see my cursor?
Yes, sir.
Okay.
Yes, doctor.
This is the chiasma over here. It is just touched up to there. It has not really caused much compression over there. Her visual acuity later on measured was 6/6. Visual fields were also normal when she became more cooperative when the headache was treated. But then look at what is her hormonal profile. What has happened? There's a very low level of T3, triiodothyronine, and there is a very low level of thyroxine. So, but the TSH levels are sky high, 150. Normal upper limit is about 5.8, and she's got 150, which is very, very, very high. I did a repeat prolactin in my hospital. It was only 25.85. It was not really very elevated. So the real problem in this patient is primary hypothyroidism. It has not manifested as mixed edema. Not all patients with hypothyroidism need to have mixed edema. They may have no symptoms other than just menorrhagia as their symptom. Sometimes they may have only psychogenic symptoms, which may be the manifestation of hypothyroidism. And this is a CT, which again shows that there is no cellar erosion. There is no expansion of the cella. The cella is normal in size, and this is the mass that is seen. It's almost uniform. There are no areas of non-uniformity to suggest an adenoma. So the diagnosis for this patient is there is a hyperplasia of the pituitary, especially of the thyrotrophs in the pituitary, due to primary hypothyroidism. There is galactorrhea, which is caused by mild hyperprolactinemia, which is due to excessive thyrotropin release hormone, and she's got migraine and tension headache. So this patient did not require surgery. All she required was thyroxine tablets. She was given thyroxine 200 microgram per day, and after 3 weeks, you see all her levels come back to normal. There's no galactorrhea. Her periods became fairly normal. The headache was resistant to migraine prophylaxis, and she improved on psychiatric therapy. And this is the pituitary CT done after a few weeks. A similar case, a younger girl who's got no symptoms of hypothyroidism. She's got normal secondary sexual characters. She's got normal vision. She's got no endocrinopathy, but there is a mass in the pituitary. You can see this kind of mass. What do you see over here? The anterior pituitary is involved, and this part of the pituitary, which is called as the infundibular portion, that on the part of the secretory gland that goes along the pituitary stalk, that also is enlarged. So this is also typical of a person who's got very high levels of thyroxine, very high levels of TSH. Here it's 116, again very high. Most of the time, this hyperplasia occurs when the TSH values are more than 50. Here also there is a slight prolactinemia. All the other hormones are normal. You can see what happened before the treatment. It was like this. And after starting treatment, the pituitary has simply melted. It has just become almost invisible now, just on 50 micrograms of thyroxine. She stopped the treatment. She came back to me, and again there is enlargement. So it's very typical proof that hypothyroidism has caused the enlargement of the pituitary. Treating the hypothyroidism made it smaller. Stopping the treatment again made it bigger. So again, she was started on higher dose of thyroxine. Then later we were able to cut down the dose of thyroxine and follow her up with this. So please remember that sometimes what looks like an adenoma on the pituitary is actually due to elevated levels of TSH being produced from the hyperplastic pituitary. I would like to show you this basic physiology phenomenon. Let me see if this works here. I think it will work. Can you all see this web page? Is this web page visible to you all?
No, sir. It's only the slide which we are seeing.
Only the slide we can see. So this is not being shared then. Okay. This you're able to see now. Anyway, what happens is there are many feedback loops that happen. The hypothalamus produces the TRH, that is thyrotropin release hormone, that stimulates the pituitary. Pituitary releases the thyroid stimulating hormone that stimulates the thyroid, and thyroid produces the thyroxine and T3. So this is a normal physiology. And the production of this starts giving feedbacks. There are indirect and direct feedback loops. And this is a control mechanism that exists. And when this mechanism overdrives the thyroid, like there's a lot of TRH, there's overdriving of thyroid. There can also be, because the TRH also stimulates prolactin, there can be elevation of prolactin in these patients. So this is just to bring back home the various feedback loops that are there, which control the thyroid production. This is the same for all other kind of hormones also. Pituitary hyperplasia is not something new. It has been known even from the days of X-rays. People have made diagnosis on the basis of X-rays, then on CTs, then now on MRIs. And this particular article is a very recent article which reports 92 cases from 96 to 2023. It studies all the cases and shows how this can be an important differential diagnosis for a pituitary adenoma. So the moment you see this, don't jump to the conclusion that this patient requires surgery for a pituitary adenoma. Now, let us say you have a patient who's got a pituitary mass on the MRI. Okay, there's a pituitary mass. You don't know whether it's an adenoma, whether it's hyperplasia. Just from the TSH and T4 levels, you will be able to make the kind of diagnosis that you need. So if the patient has got a normal TSH, normal T4, the patient is basically euthyroid. And if there is still a mass, the mass is due to something else. It may be a FSH producing adenoma, it may be a growth hormone producing adenoma, it may be any other adenoma, or it may even be a non-functional adenoma. Now, when the TSH is normal and the T4 level is low, then it's a mixed case of primary and secondary hypothyroidism. That means there is an adenoma, there's also primary hypothyroidism. I have a case like this, but because of shortage of time, I will not be showing this particular case today. And if the TSH is normal and the T4 is high, this is an unusual phenomenon, because if there is a T4 high due to primary hypothyroidism, it should suppress the TSH. The TSH should go down, but that's not happening here. In that case, you should measure the free T4. The free T4 is usually normal, and these patients are euthyroid, and this often happens in pregnancy. So please remember this. So if you get a value like this, please make sure that you check the free T4, not the bound T4. And this is due to physiological hyperplasia. The mass enlargement is due to physiological hyperplasia. Similarly, if the TSH levels are low and the T4 level is normal, then it is hypothyroid still, but it is not producing clinical manifestations. If it is low TSH and low T4, it is secondary hypothyroid. That means the patient has got clinical manifestations of hypothyroidism. There is a mass lesion in the pituitary which is causing this. The rest of the cells become atrophic when there's a big adenoma, let's say a proactinoma or a non-functioning adenoma that compresses the pituitary. The rest of the cells become less active. Therefore, there is hypothyroidism. This is called secondary hypothyroidism or pituitary hypothyroidism. And when the TSH level is low, but the T4 level is high, it is an independent primary hypothyroid. That means there is patient has got basically Graves' disease, but there's also an adenoma, and often this adenoma is a growth hormone secreting adenoma. Then you have this combination. This is reported in this particular paper, growth hormone secreting adenoma and Graves' disease. Now let us say the patient has got a high TSH, the T4 is normal. This is what happened with some of our patients. It's a TSH adenoma. We have diagnosed TSH adenoma based on this combination alone. And now you saw 2 or 3 cases of primary hypothyroidism where the T4 levels are low, and secondary hypothyroidism where there is a TSH adenoma. So this is the kind of flow chart from which you can basically make a diagnosis of what is the kind of mass lesion based on just the 2 simple factors, TSH, T4, and if necessary, free T4. Okay, now we'll go to shift gears and go to another kind of problem. This is my second patient, client. She has 2 years of recurrent holocranial throbbing headache. At the height of headache, she has vomiting, but there are no visual symptoms, very typical symptoms of migraine. The headache has been precipitated by sun exposure, travel, sleep loss, etc. She's had normal cycles. There's no galactoria, fundi and fields are normal. She has no endocrinopathy. We think she's got a migraine and tension headache. She's only 17 years old. But look at what has happened to her pituitary. The pituitary looks quite large. And this patient was also offered surgery for biopsying the pituitary because they thought there was something wrong with the pituitary gland. But then, because all endocrine tests were normal, we thought this was only a physiological hyperplasia. So this is a different condition, a physiological hyperplasia that occurs during puberty and pregnancy. So this is a pubertal hyperplasia. So this patient did not require any surgery. Her headache became better with migraine. And after 3 years, I got another MRI done, and it shows that the pituitary that was this big has become this small. So it's a normal involution of pituitary that happens after the pubertal age is gone. So this is another factor you should remember. So first we saw a patient who's got pituitary hyperplasia due to hypothyroidism. Then we are now seeing a patient who's got a physiological hyperplasia of the pituitary gland. These are not tumors, they mimic tumors. They should not be operated. Okay. Now one more different kind of problem. A 17-year-old girl, 3 months of recurrent bitemporal headache. She's occasional vomiting, no visual symptoms. She's feeling very low on energy. She's feeling feverish. She's got polyarthralgia. Obviously, she's got some systemic problem with all this feverishness and polyarthralgia. Her menarche was at a normal age. She had regular periods. There's no galactoria. Fundi fields are normal. There is no clinical evidence of endocrinopathy. This patient was also posted for surgery elsewhere for this mass that is there in the pituitary gland. You can see that there is a mass which is enhancing very well. There's even a small area of non-enhancement, which suggests that this might be an area of hemorrhage or an adenoma that is less enhancing. But then you can see that the enhancement extends all the way up to the infundibulum. The whole of the pituitary gland is enhancing, and not just one area that is enhancing. So in her, we thought we should think of a different diagnosis because she had no other pituitary symptoms at all. So we got a ESR, which was very high. Her all other inflammatory parameters, like the one that is done for sarcoidosis, one that is done for cancer, panca, etc., anti-dsDNA or systemic diseases, they were all negative. So all endocrine tests were also normal. So we made a provisional diagnosis based on the imaging and the clinical picture as lymphocytic hypophysitis. Of course, the final diagnosis can be got only by biopsying that lesion, but that means surgery. You cannot get a biopsy without surgery. So we thought, okay, if it is lymphocytic hypophysitis, why don't we try a course of steroids? And that's what we did. Oral prednisolone was given for 3 weeks, just as you treat any other autoimmune disease. And after 6 weeks, you can see that this big pituitary has become so small. It is still enhancing, but pituitaries should enhance. Normal pituitary should enhance, and this looks like a normal pituitary to me. So we have hit the diagnosis without having a tissue diagnosis. And the entire syndrome you should consider to make a diagnosis of lymphocytic hypophysitis. Lymphocytic hypophysitis can be either idiopathic or it can be secondary to diseases like sarcoidosis, tuberculosis, Langerhans cell granulomatosis, vaginous granulomatosis, and another rare condition called plasma cell-rich IgG4 related hypophysitis. All this you can get only from tissue diagnosis. It can also be based on histology. It may be lymphocytic, there may be granulomas, there may be xanthomatous form, there may be xanthogranulomatous form combinations, and pituitary granulomas with a lot of necrosis. This patient probably would have had that kind of thing because there was one small area that was not enhancing in this patient. You can also base it on the area of the pituitary that is involved, only the adenohypophysis, only the infundibular neurohypophysis, or the infundibulopan hypophysitis, various types that are there. Anyway, good to remember this diagnosis because you can spare the patient of an unnecessary surgery. So let us see what are the causes of pituitary enlargement in imaging. Majority of them do have adenoma, but the gland itself, the whole gland itself enlarges in the physiological conditions like puberty and pregnancy, also in hypophysitis, thyroid hyperplasia, thyrotroph hyperplasia, and primary hypothyroidism. We saw cases like that. Similarly, if there is ovarian failure, there is need for higher and higher levels of gonadotrophins. So the gonadotrophic cells become hyperplastic, and that becomes a pituitary mass. It can also happen with intracranial hypotension. You can see these are the cases. This is intracranial hypotension. You can see all the other features of primary intracranial hypotension, which causes the pituitary enlargement. So please remember that there are many other causes other than just adenoma, and you need not operate on any of these cases except the pituitary adenoma. Now, if there is a problem of diagnosis, can imaging help you to make the diagnosis? You can note these following features: the flat lower border in the coronal image, and this triangular shape. It almost looks like a hut that is drawn over here. And this is a typical finding that I see in every patient who's got a pituitary hyperplasia. You never see this with an adenoma. You will see adenomas later. You will never see this kind of picture. And you will see that the whole of the pituitary gland, including the infundibular portion, is involved. There's a uniform signal character, uniform enhancement. And if you do dynamic contrast enhancement, you will find that the top part enhances first, And then the lower part enhances, because that is how the circulation comes down over here through the plexus, the hypothalamo-pituitary plexus. Now we go to another problem which was really surgical. This patient had nose block and anosmia. So he came to the ENT surgeon for impairment for his symptoms, but he also had left eye visual impairment. A transnasal biopsy had been done elsewhere because the mass was visible in the nose, but it was inconclusive. And after the biopsy, he started getting recurrent epistaxis. And when you look at his nose, you can see the mass that is coming out of the middle meatus. And he had very poor vision on the left eye. Right eye vision was good, but there was a field cut. You can see the field cut on this side. And there was primary optic atrophy here. There are no other neuro or endocrine signs in this patient. And you can see what a huge mass this man has got. It's going into the nose. It's going towards the frontal sinus. It's going towards the frontal base. It's lifted up the whole of the frontal lobe. It's involved the entire pituitary gland. It's going into the clivus. And it's extending so much. This is really a very big, very huge mass. We are not sure what this is. It has obliterated all the normal structures over there. It has destroyed all the bones over there. And you can see how much of intracranial extension, frontal extension is there in this patient. So normally we say a pituitary adenoma is a giant adenoma, where it is, some people say 3 centimeters, some people say 4 centimeters. But this one measured 9.2 centimeters in the largest axis. So it's giant of giants. So what do you think we should do? We told the patient that we will try getting it out through the nose, but we will not be able to get everything out. There'll be a lot that is left behind. We'll have to do craniotomies, maybe 2 stages of craniotomies, because it's in so many places inside the head. All these things we prepared for him. And then we took him up for surgery through the nose. So what was actually done was we did a bilateral thermolytictomy. The tumor was very suctionable, so it was a little easy for us. And tumor had done most of the dissection and destruction. So we didn't have to do much of drilling. Tumor had done all that for us. Went through the middle meatus, went to the maxillary antrum, got the tumor out from the maxillary antrum, went into the ethmoid sinus. We did the coagulation of the blood vessels that supply the tumor, including the sphenopalatine arteries. The cellular and clival parts, all of these were taken out through the nose. And to take this out, we had to go through another approach. You use an angled endoscope, go through the superior meatus, do a draft 3, get all this out. And fortunately, this entire tumor had just lifted up the dura. It was not invading the brain. It was not invading the dura also. The dura was intact in this patient. And so the whole subfrontal extradural tumor was completely removed by this, and then hemostasis was achieved. Now you have a big problem. You have a big defect in the skull. You have to reconstruct it, and none of the usual flaps that we raise from the nose, like the Haddad flap, is available for this patient. So what we did was we took the pericranium from down, right, all the way from here, and turned it into a vascularized flap, put it in through the frontal sinus, brought it out here, and brought it all the way up to the clivus here. This very long pericranial flap was, vascularized pericranial flap was brought down here. This patient did very well. So this is the kind of reconstruction that we did. So whenever we plan this kind of surgery, we should plan the reconstruction also ahead, and we should be able to take this out. And this is a post-operative. You can see in the clival portion, all this portion has been completely removed. I'm not sure whether this is just normal cavernous sinus enhancement or whether there is a little residue over here. But most of the tumor, though it was very large, we were able to take it out entirely through the nose without an incision on the head. So that is a giant pituitary adenoma. From the smaller lesion that you saw, this is a big jump and a huge lesion here. And this is visual recovery. Even eye in which there was no vision, there is a good vision now, and this vision has become much better. People have studied this, and often combined approaches are required, but at least in these patients, we are able to take it out through just one particular approach. Now let's go on to my 5th patient. She has progressive loss of vision in the outer half of the eye type, post-menopausal patient, so there's no menstrual history to take here. And this is her typical bitemporal hemianopia. This temporal field are gone. And this is a mass. Now we have a problem here. We don't know what this lesion is. Is it a pituitary adenoma or is it a meningioma? Meningioma is more common in this age group, post-menopausal age group. It's uniformly enhancing, and it is quite nicely lobulated like this. It doesn't have that bulges which are usually seen in pituitary gland. There's not much of pituitary enlargement at all. The cellular enlargement is not there. And you can see that this is rather flat over here. So we thought this might be a meningioma, but still, and you can see this, what is called as dural tail sign. This is the dura over the clivus in the plane scan. And this is the contrast scan where you can see a beautiful enhancement over here. This dural tail sign is not specific of a meningioma, but is more common in a meningioma. It can occur even in the pituitary adenoma. So we really do not know before surgery whether this is a pituitary adenoma or whether it's a meningioma. Still, we decided to take the chance because it appeared as if it could be taken out through the nose. We went in through the nose for this patient. You can see these are the other remaining pictures. You can see the close relation to the carotid arteries over here, both carotid arteries, and to the basilar artery posteriorly. And that is on the CT angiogram. So now to distinguish between a meningioma and a pituitary adenoma, we have several methods by which we can use, but these are not always foolproof. Like for example, in CT, you might find in a meningioma there is bone sclerosis, whereas there is bone lysis with the pituitary adenoma. In MRI T1, this is iso-intense, whereas this is often hypo-intense. And there is non-uniformity in the pituitary adenoma because not all areas will be the same. Some areas will be necrotic, some areas will be hemorrhagic, whereas meningioma is usually uniform and it enhances also uniformly. The border is lobulated, the pituitary adenoma is smooth like in this patient. The angle with the planum is acute or obtuse. Cavernous invasion is common with pituitary adenoma, but not with meningioma. And dural tail sign can occur with both, but it is pathognomonic, not pathognomonic of a meningioma. So this was the kind of picture that we had. So we went in through the nose, removed it. It fortunately turned out to be a pituitary adenoma. We were able to remove it completely. If it is meningioma, it would have been more difficult to remove, but not impossible. We do a lot of meningiomas also through this route. Good visual recovery in this patient. And this is the MRI after 1 year, showing complete removal of the tumor. You can see that the pituitary stalk, the posterior pituitary, everything is intact here. In fact, there's a little prolapse of the blood vessel into the empty space that is left behind by the removal of the tumor. 6th patient, again a lady, 45 years old, 3 months, right eye visual impairment. She's got no vision in the right eye, almost no vision, just perception of light, primary optic atrophy in that eye. Left eye is normal. Again, there's a mass. Now, is this a meningioma? Is this a pituitary adenoma? We don't know. But here, what is happening is there is too much of close relation to this carotid artery. This we were not confident of being able to handle through the nose. So we decided to go by the orbitofrontal approach for this patient. To some extent, you can see that this is the pituitary gland that is enlarging and this is the tumor that is there above. And this is the angle with the planum is obtuse over here. All these features suggest that this might be a meningioma. And so we went in through the transcranial route. And there's also calcification in the CT over here in the near the planum. So this we thought was a diaphragma cellular meningioma. And I have written this chapter on supracellular meningiomas in a textbook. And this is the pictures that I've used over there, the pictures drawn by me. So this is the diaphragma, this is the anterior pituitary, this is the posterior pituitary and the stalk, and this is the infundibular portion. So this type A meningioma arises anterior to the stalk and it projects above the cella. It just dips it a little into the cella, but the diaphragma you'll be able to see the pituitary in this enhancement separately, like you saw in the previous patient. Type B arises posteriorly, so it is the stalk is in front. So you have to come from a lateral approach. You cannot come from front because then you will hit the stalk first. Type C is occurring within the cella. Type D is not really a diaphragma cellular meningioma, but it comes from the side walls of the cellular dura. So in this patient, I did a suprabrow incision, a craniotomy in the just above the brow, and then we were able to get this entire tumor out. The right optic canal extension was also removed. Stalk was preserved. She had uneventful recovery. The histopathology was a meningioma, grade 1 meningioma. This is an immediate postoperative CT. There was unfortunately no vision in the right eye, and this is the importance of detecting these lesions early. If you detect the lesions early, you will be able to save vision. Once the vision is already gone, you will not be able to save it, but you will be able to save the vision in the other eye. And this is the MRI after 1 year. You can see that the tumor is completely removed. My last case here, this is a different story altogether. This is a 29-year-old man. He got loss of appetite. He got headache. He's sleepy all the time for the last 5 days. He's got slightly disoriented speech and confabulation. So this is his presentation. And what you find on examination is fundi are normal. Of course, because of his sensorium, he cannot check the visual acuity or visual fields well. But the eye movements and pupils were normal in this patient. This is the kind of mass he has got. This mass is projecting into the third ventricle. It looks cystic. It looks just like the water that is there inside the ventricle. You can see this is a mass. It's on the CT. And this is caused block of the foramen of Monro. So there is dilatation of the ventricles over here. What do you see in this? There's something very peculiar over here. There is a cystic mass, but on the bottom of the cystic mass, there's something that is black over here in the T2 weighted image. This is his 3D image. You can see that this mass is there. This becomes exactly the opposite in the T1 weighted image. This will be bright, whereas that will be dark. So we have a differential diagnosis of a cystic craniopharyngioma or a rare condition called Rathke's cleft cyst. I'll tell you what this Rathke's cleft cyst is all about. And please note this particular thing, this black dot marked with an arrow over here. This is a very pathognomonic sign of a Rathke's cleft cyst. Rathke's cleft is actually a normal anatomical structure that's there during embryological time, and as the neural ectoderm and the pharyngeal ectoderm, oral ectoderm, they meet together and they form the secretory pituitary gland. It gets pinched off. The sphenoid sinus forms over here. This forms the adenohypophysis, and this forms the neurohypophysis. And in between the two, there is a pars intermedia. So if you get a cystic collection over here in the pars intermedia, then that becomes a Rathke's cleft cyst. Now the pars intermedia extends all the way over here. So the Rathke's cleft cyst can be here, or it can be also over here. So it can be either inside the sella, or it can be inside the sella going up above the sella, or it can be entirely above the sella. So this is the kind of embryology of the Rathke's cleft cyst. On imaging, it is usually situated between the anterior and intermediate lobes of the pituitary gland. So that is the obvious location, because it's a pars intermedia cyst. 40% are intracellular, 60% have supracellular extension. Purely supracellular is rare, like in this patient, which I'm showing you now. The non-contrast CT shows a non-calcified tumor, and that is very important because craniopharyngiomas, often there is a calcification in the wall. In MRI T1, it is either hyperintense or hypointense, depending upon the protein content. In T2, it is mostly hyperintense, but sometimes it is isointense. In contrast scan, usually there is no enhancement. Craniopharyngioma will show some enhancement here and there where there is solid tissue. And this non-enhancing intracystic nodule is seen in 75% of cases, and that is pathognomonic, what I had marked with the arrow in the previous picture. And rarely there may be some fluid levels because of hemorrhage inside the cyst. So now how do you approach this lesion? If you want to come from below, you have the whole of the pituitary gland over here. You'll have to disturb the pituitary gland to get into this. So that is not the ideal thing to do through the nose. And because this lesion is extending so much into the ventricle, coming from any pterional approach or orbitofrontal approach is not also going to help you, because so much of it is inside the ventricle. So the most direct approach would be to come through the ventricle itself. You can come directly from there with an endoscope, right from the top, make a craniotomy in the frontal region, and then start coming down from there through the endoscope, come inside here, through the foramen of Monro, get into the cyst, empty the contents of the cyst, peel off the wall as much as possible, remove this intracystic nodule. So this is what we did, entirely endoscopic surgery from the top. Transcranial endoscopy, you can see this is a burr hole, and this is a catheter that is there after surgery, and this is a catheter that is there. The entire tube, this big mass is gone over here. Everything has been excised and it has been emptied. And this is the picture after 1 year, the MRI after 1 year. So now I have shown you 7 different cases, the 7 sellar masses. And what is the take-home point from these masses? First thing is, whatever be the imaging findings, clinical history and examination are vital. Don't miss out things like menstrual history. And these are often done in a busy clinic. Then in most patients, you would require both CT scan as well as MRI, vision tests, endocrine tests. Put all the information together, the clinical findings, the CT findings, the MRI findings, the vision test findings, the endocrine findings, put them all together and come to a conclusion. Before, don't rush in to operate on every single sellar mass that you see on imaging, because some of them will not require surgery and some of them will actually be harmed by doing surgery. And once you decide to operate, then you have to choose wisely the approach. We have 3 basic approaches. One is endonasal endoscopic, which is the workhorse for most of us. Sometimes we need the transcranial approaches, especially for some meningiomas. And for the cystic lesions that you saw, like craniopharyngioma, sometimes you may employ the transventricular endoscopic approach. And whatever you do, you have to keep the patient on a good clinical, endocrine, visual, and imaging follow-up. All these are absolutely essential. So these are my take-home points from the 7 sellar masses that I've shown you today. I hope I have finished on time. Thank you so much.
Sir, thank you, Dr. Ramakrishna sir and Ashokan sir for the exhaustive lectures.
Great opportunity for neurosurgical forum to have both Ramakrishna Iswaran sir and Ashokan sir, as we have all received good amount of clinical judgment, interventional, and treatment options available for both ischemic stroke as well the sellar masses. I think nearly about 170 attendees were there during the entire program. It would have been well appreciated by all of them to receive practical and useful information about both the topics. With more than 40 years of experience for both this senior neuro specialist, we would have had excellent informations. Thanks one and all for taking so much of effort to make this information available to all of us. In every month, we will have different senior speakers as well junior speakers for various topics about neurology and neurosurgery. Hope to meet more people and share our knowledge to improve neurological care in India. Thanks a lot, sir. Thanks a
Next
lot.
month, we will be having the meeting on August 19th. Same time.
Thank you all. Thank you all.
Thank you, Dr. Rajesh
Bye-bye.
Babu, and thank you, Vikram.
Thank you, sir.
Thank you.
I'm leaving.